everyone. Thank you so much for joining us. This is being recorded, just an FYI. All right, so chances are you're here because you've gained 5 to 20 pounds in the last few years. Women, if you're in menopause, it's typical to gain about 1 kilo a year during perimenopause. And perimenopause lasts about 10 years. So that's potential for 10 extra pounds or kilos over that time. And now that's leaving you feeling frustrated, shameful, and possibly even depressed. And then you heard about this new drug, Ozempic. I bet you have at least one friend who's found this to be some kind of miracle drug, and it's left you wondering, is this right for me? Then you've heard about all of the negative things, the possible thyroid cancer, pancreatitis, Ozempic butt, Ozempic face, and the shame. There is so much shame and judgment when we even say the word Ozempic. As a matter of fact, I even got an email shaming me for giving this talk, telling me that they thought better of me as a naturopath, and how can I give a talk on this kind of poison, which made me feel even more, how important is it to get this information about? Whether or not it's right or not right, we need to be informed because it's here and it's here to stay. First, let me introduce myself. I have been in the weight loss business for about 30 years. First as a fitness instructor, a personal trainer, now as a naturopath, but possibly like you, someone who has always struggled with her weight. I've done my genetic testing, and sure enough, it says I'm most likely to be overweight or obese. When I was in high school, when I would walk in a room, I would look around, and the first thing I would look at and I would think is, am I the biggest one in the room? I'm pretty sure my mom had an eating disorder. When I was in grade 8, I remember thinking, once I get into grade 9, I'm going to have to start eating just like my mom. Well, what my mom would eat every morning, she'd have a coffee with cream. At lunchtime, she'd have half a pack of Melba toast, some cheese and an apple, and dinner, something similar, maybe a bit of chicken. So when I was 14, 15, I went to my doctor and I told him that that's what I was eating. And his response to me was, you're eating too much. Now, think of that. Here I was, a 15-year-old girl. I finally got the guts up to go talk to my doctor to ask about how to eat better. And that was the advice he gave me. Now, luckily, I never did get an eating disorder. I found sports and many other things. But back then, there wasn't a lot of information when it came to weight loss. Now, I would say there's too much information when it comes to weight loss. Everyone thinks that they're the expert. Well, I'm happy to say that I truly do think that I'm the expert, having worked on this for 30 years. And then when this new drug, is it new? We'll talk about that. But when we heard more about this drug, Ozempic, came out, I really felt like it was my duty to make sure I did a really deep dive into it for you, for my patients, and for myself to understand it. So a lot of you have heard of Tina Moore. She is on almost all the talk shows right now talking about microdosing, the GLP1s, or semaglutides, or Ozempic, all the same thing. I'll use the name interchangeably. So I took her course. I've done tons of research on my own. And so I'm here today to give you a lot of the information that I've picked up, to answer some of your questions, and we'll take it from there. But first, let's talk about some facts. The fact is that weight loss is hard. The global weight loss market was valued at about $260 billion in 2022, and it's expected to double over the next 10 years. So that means there's a lot of people spending a lot of money on weight loss because it's not working for them. And as we mentioned earlier, it's even harder when you're in menopause. We talked about that 10-pound weight gain, 10 kilo weight gain that we see during the menopause years. Well, increased weight increases your risk of chronic disease. Let's just take that 10 pounds only and look at it in more detail. So my focus is anti-aging, hormones, and brain. So as knowing those are my focuses, and weight loss. As you can tell, I'm pretty passionate about this topic. But let's take just those 10 pounds. So 10 pounds of extra weight on your joints is putting about 30 to 60 pounds with each step. This can lead to joint pain and damage, increased cartilage breakdown. That increased 10 pounds on your heart is causing it to possibly enlarge, weakening possibly over time, increasing blood pressure, possibly arrhythmias. And every year, 10% of cancers in women are attributed to excess weight gain, and 5% in men. So weight loss isn't just hard, but it also can be very detrimental and a problem when it comes to chronic degenerative disease. All right, keeping those facts in mind, now let's talk about some myths that we hear out there. The myth is that people who are overweight have no self-control. We'll talk more about that. The myth that your body wants to be at its ideal weight, it doesn't. And this idea that GLP-1s are new drugs, it might have hit the market once we heard more about the Ozempic, but it's been around for quite a while, and we're going to talk more about that. So let's start first off with this myth that people overweight have no self-control. Genetics play a big role when it comes to this. As I mentioned, I did my genetic testing, and sure enough, says that my genes show me that I'm going to have a problem when it comes to weight. Genes influence how efficiently your body can burn calories, and they also play a massive role when it comes to hormone regulation in satiety. So satiety is that feeling of fullness, and so it suppresses the desire to eat. And it's regulated by a very complex interplay of hormones and peptides between the gut, pancreas, and brain. And so these are part of the hormones that are playing in the hunger dance. So leptin is your or satisfied feeling. So leptin gets produced by your fat cells to say, hey, you're full, stop eating. The opposite of leptin is ghrelin. And ghrelin is produced by the stomach to say, hey, eat. Insulin also does have a role when it comes to satiety. It also works on the hypothalamus to say that you don't need to keep eating. But how does insulin get produced? And it's by these molecules, these peptide signaling molecules called incretins. And you might not have heard about incretins before, but incretins are GLP1s or GIPs. So GLP1 is a peptide that's produced in your body, in the gut, so secreted by the intestines. And its function when it comes to satiety is to slow down emptying and reduce appetite by acting on the hypothalamus. And it also reduces those hedonistic urges, so a lot of those cravings. So here we know that we need the gut to be functioning well, to produce these incretins, to get the pancreas to produce the insulin. And so it's interesting because insulin is our hero. I know so many of you have heard about insulin. We know that it puts the glucose into our cells because the glucose is poison when it's running around the body. But how many of you heard about those unsung heroes, the incretins, that are actually putting it inside to make it work? And so I wanted to do a deeper dive. What else do these GLP-1s do? As a brain doc, remember, that's one of my big focuses. We now see, so GLP-1s, just like it's a peptide, but it's like a hormone because it's a signaling peptide. So I might call it a hormone throughout this talk as well. So GLP-1, produced by the gut, goes to the brain, and it is also neuroprotective and increases neurogenesis. So as a doctor who focuses on brain health, that's something that I have to pick up and notice. As a doctor who focuses on anti-inflammation, I also have to pay attention that it works on the immune system to decrease inflammation. So we know that GLP-1s are produced in our own body by the gut. There's receptors, all the organs and systems in our body. It's anti-inflammatory. It makes us more sensitive to insulin. It supports satiety. It's neuroprotective. And what are peptides? So peptides heal and rejuvenate in our tissues. So that's what peptides do. For some reason, we can't get them naturally in Canada, but our body makes them. But in the States, most of the anti-aging docs do a lot of peptide work. So as an anti-aging doc and anybody who's starting to age, which is all of us, we know that low-grade inflammation is associated with a lot of risks of disease. And so any strategies that are going to help decrease inflammation are strategies that it's worth us understanding whether or not we think it's going to be right for us. And so we can get deficiency in GLP-1. What causes you to produce less of these peptides? Insulin sensitivity. So if you're sensitive to insulin or insensitive, we're going to see a decrease in GLP-1s. Gut health issues, we're going to see a decrease in GLP-1s because that's where they're produced. Aging naturally decreases our GLP-1s. Chronic inflammation, metabolic syndrome, we're going to talk more about that. Obesity, and pancreatic and liver disorders. Now, perhaps you're producing enough GLP-1, but your body's becoming resistant to it. So just like your body can become resistant to insulin, so too can your body become resistant to GLP-1s. How can that happen? Well, different genetic variations can cause that. High insulin can cause that, inflammation, as well as beta cell dysfunction. And what are some of the symptoms? Well, increased hunger, difficulty feeling full after a meal, weight gain, poor blood sugar control, and reduced energy levels. Is this resistant a normal thing? It is. So we can become resistant to pretty much any hormone. If you're constantly being bombarded with a signal, think about perfume. When you first put perfume on, you can smell it really, really a lot. After a while, you stop. When I treat people with kids, my kids were young as well, the kids could be nagging at the parents, asking questions, and I could completely tune it out because I was resistant to kid pestering because I was getting it so much at home. Now, if I have a patient come in and their kids are asking a lot of questions or being involved, I can't help but pay attention to them because I'm no longer kid resistant. And so what happens when we're hormone resistant? How it's supposed to work is the insulin or whatever that receptor is here and the hormone attaches to it. Now, when we become hormone resistant, that receptor cleaves off. And now that hormone that was supposed to go into the cell and have some kind of metabolic function isn't going to get in. So now we can't predict how the body is going to react and the whole metabolic system just goes sideways. So if we talk about how insulin works, here's a great example. So glucose is poison outside the body. We know that, high glucose, can cause diabetic retinopathy, diabetes, amputation. So glucose needs to get inside the cell where it's going to do its work. So what happens when everything's working well is that insulin binds the insulin receptor, and it's that binding that causes this glucose channel to open, and now glucose can enter the cell. Now, a lot of you have probably been told you're insulin resistant. If you're insulin resistant or diabetic, it means that you've been swimming in a sea of insulin and glucose outside of the cell, this resistancy, for about 10 to 15 years. And so this is what what's happening to you. We're not getting that hormone resistant, but 10 to 15 years. Imagine if we start thinking about prevention. And one of the things we can start thinking about that way is metabolic syndrome. About 40 to 45% of the world's adult population has metabolic syndrome. And it's one of the leading causes of more chronic disease like cancer, dementia, heart disease. And so do you have metabolic syndrome? Well, one of the quick and easy ways to start thinking about it is that apple shape. So that apple shape, that fat that goes around the waist, people often call it the menopause weight because we get it when we're older, but that's because things aren't functioning as well. Or the cortisol weight, but we often see a lot of men with that, where they've got that big visceral area right around the stomach. This is sick fat. So this fat is actually causing a lot of negativity to the body. What's happening is you might think though those fat cells in our body, those aren't just passive little cells that are sitting there. They are actually metabolically active. And that bad fat, that visceral fat that can sit there, it causes inflammation. It attracts inflammatory cells. And what's that going to do is going to increase our fat. So now we're getting that cycle of one of the reasons why we keep gaining weight. And I'm going to talk more about that after. And another thing that happens here is we get a cell danger response. So what happens is that just like if I were going to attack your home, you would close the door, you would bring up the drawbridge. And so that's what happens with the cells. The cells think they're in danger because there's inflammation. They stop allowing nutrients to flow freely inside and outside of the cell. So your body, it sees the glucose there, but it leaves it. It's not going to bring it up, leading to more insulin sensitivity. So getting that fat weight around the stomach is one of the really important things that we need to think about when it comes to chronic disease. And it's not about being skinny. It's about that ratio. As a matter of fact, that hourglass figure, the 0.7 ratio, is actually called the fertility ratio because people who have that ratio, the waist to hip ratio, actually have the highest level of fertility, which is interesting. So it's not about aesthetics. It's about your body being at its optimal. And it does play a role in how efficiently are your hormones working, because excess fat disrupts the body's finely tuned hormone balance, particularly hormones that regulate things like fertility, but also hunger, fullness, and energy. And we know that resistance can happen with any of our hormones, but particularly leptin and GLP1s are the two big ones that are going to play a role when it comes to satiety. So putting aside that myth, people that are overweight, it's not because they're overweight because they can't control themselves. It is hormonal changes in the body. Now, let's also put aside that idea that your body wants to be at its ideal weight. That is completely incorrect. Your body, especially once you've given it a taste of a few extra pounds, women think pregnancy and you've gained that weight, your body wants to go back. It's going to work hard to create that homeostasis again. It's created a new set point that every cell has to think about. But this is also due to evolutionary biology. Your body wants to protect its fat stores. It sees fat stores as its protection against starvation. We haven't evolved enough to deal with the modern world environment where we have so many high-calorie food. So when you begin to lose weight, your body interprets this as a threat to its very survival, and it adjusts its hormones, appetite, and metabolism to conserve energy and regain that fat that was lost. So this is a normal cell for a second. I know I'm using this leptin resistance, but I just want you to think about leptin for a moment. In normal fat cells, so normal fat cells, we get lots of fat being produced. If they're bigger, the more fat cells you have, the more leptin gets produced, and the more leptin causes this anorexic peptide, so the peptide to say stop eating, to come out. And so we decrease our food intake and we increase our energy expenditure. Now, if we have less fat, then we have less leptin being produced. And so now we have less of the molecule telling your brain to stop eating. And that's a normal function when you lose weight. So this is not talking about metabolically inappropriate responses if there's leptin resistance. This is a normal response. Less fat cells equals less leptin equals less hormone to your brain to say you're full. And that's another reason why typically we begin to gain our weight back again, because your body wants to hear that leptin as we heard it before. And so when I was doing all of this research and I'm seeing so many of the different benefits that these GLP-1s could do for us, I did have to wonder, is Tina Moore right? Could we treat GLP-1s like we do other hormones? Low dose, go slow, work up to buy us time as we fix all the other things going on. I was in Detroit a few years ago, and I grew up in the 80s. And so I was told that Detroit was this extremely unsafe, high homicide, dirty place to go. It was beautiful. It was nicer than Toronto. And I asked someone and they said that, a while back, the mayor had put a police officer on every corner and they had just really changed things up. They had fixed the problem and now it was a clean, beautiful place. Could we do something similar to our messed up metabolism? Because the truth of the matter is that our bodies are not evolutionary adapted to understand the world of excess that we are in right now. So instead of judging people and situations that may be beyond their control, we need to harness harness the information we have and make informed decisions to our next step. Just like bioidentical hormones, we think of them as supportive hormones, using the lowest dose possible to provide the effects that we're looking for. We regular monitor, we ensure that all of the information, the pros and the cons are on the table, and lifestyle changes are non-negotiable. And so could we use just a small amount of GLP-1 to allow the body to start hearing insulin again? And would it benefit other things along the way as well? It's actually cardioprotective. It actually is brain supportive and bone supportive. So keep that in mind. So again, GLP-1s are things your body makes naturally in the body. Now, GLP-1 agonists, that's what Ozempic is. So these are slightly changed in order to last longer. So GLP-1 is a naturally occurring peptide in your body that your body makes. And in the States, you can actually get this from some compounding pharmacies. Because it's a naturally occurring peptide, they cannot patent it. Now, unfortunately, in Canada, we're not allowed to get peptides for whatever reason. So we can't get a compounded version, and we would only be able to get the synthetic version. So that is one negative thing that we have to think about. But what they've done is they made it slightly different so that it lasts longer than our own GLP. And so the first GLP-1 was made in 2005. They've actually been around for a long time. And you can see here that there's quite a lot of research and information when it comes to studying and understanding GLP-1s. Now, are there side effects? Yeah, there are going to be side effects. Absolutely. And so let's talk about them and what they mean. Let's just even go back to this document that was showing what natural GLP-1s do in our body. If we go to the brain, it decreases your food intake, which is one of the things that if you're using it for weight loss, you're going for. But decreased food intake can also mean malnutrition. Dehydration, that's a big possible side effect, and it can land you in the hospital. And if we look again, what's do GLP-1s do in the brain? They decrease your desire to drink. Now, if we go to the stomach, we see we're going to get decrease in gastric emptying. Well, have you ever eaten so much, you've gone out for dinner, maybe to a buffet, and you felt like you ate so much that you want to throw up? Well, that could very well happen, especially if you increase dose too quickly or go too high a dose. And how did you feel when you left that restaurant? You felt nausea. Perhaps you wanted to vomit. You might have had diarrhea or constipation later on. And absolutely, we're having delayed gastric emptying. And there's also decreased acid secretion. So what does that mean? That means you're not going to necessarily absorb your food as well, again, resulting in possible malnutrition. So it means that if you're going to do it right, so sometimes I'll say, Ozempic done right, it means that we have to address all of these factors. We need to make sure that these side effects aren't going to happen. And we know that people with metabolic issues like GERD, SIBO, other gut problems, it might be worse for them because the gut's already in a messed up place. Another thing that happens when you do any kind of dieting is we often see the microbiota change. The microflora actually changes. And in some people, if they have a lot of overgrowth of fungus, of candida, there's a die-off reaction. Now, this die-off reaction can cause symptoms. And even just the very fact of losing weight can cause toxicity reactions because those fat molecules we talked about, they actually hold toxins. And when you lose them, those toxins come out. So a lot of people do find feeling nauseous, fatigue, other symptoms can just be around that weight loss. So those are some of the most common side effects. Another big common side effect is muscle loss. And this is one of the reasons why losing weight rapidly is definitely frowned upon, and why I think that regular ramp up is something that most of us have to be very careful and wary of. So with all weight loss programs on a low calorie diet, the average muscle loss is 20 to 30% because you're in a catabolic state. So you're breaking down. And so on GLP-1s, we're seeing it's about the same, 20 to 30%. Now, this is very detrimental, especially when you want to think about longevity. One of the most important things we want to have is an increased muscle mass, but it's not the GLP-1s causing this to happen. It's the weight loss that's causing this to happen. So again, it goes to the how to do GLP-1s right. Now, another name for GLP-1s are semaglutides. And so I think in this next one, I refer to it as semaglutides because of the study I was looking at. But blurred vision. So let's talk about blurred vision. Blurred vision is a common occurrence when we change the sugar in our body. It's because the lens in our eye is going to have to adjust to what's going on with the sugar regulation. And so it's normal. So if you get diabetes, blurred vision is one of the symptoms. And as these changes in the amount of sugar that's being released, we're also going to see the blurred vision. Now, it's a temporary side effect, and people who are older are going to have more of an issue with this. And that's because the lens in our eye is less flexible as we age. So it's going to take longer to stabilize. Now, retinopathy. Retinopathy is a very serious complication of diabetes. It's caused by high blood sugar in the eye, and we get these blood vessel damage because we know that too much sugar causes vascular damage. One of the reasons blindness can be a side effect of diabetes. And so with semaglutides, what they had found was that 10 to 20% of patients saw diabetic retinopathy worsen. And so that's when, some of the big scares came out. Now, the most recent research on this, they did a big study with that, and they found that it's an early symptom. So they're calling it early worsening. And interestingly enough, it actually seems to get better with the semaglutides over time than if it didn't. But again, semaglutides done right, Ozempic done right, making sure that if this is something that you ever would consider doing and you have diabetic retinopathy, if right now your optometrist is seeing you once a year, then maybe you need to change it to 6 months. If it's every 6 months, maybe you need to have them see you every 3 months. It's definitely having closer monitoring would be advised. And if you have diabetes or you've started to have eye issues, getting a pre-screening is also definitely going to be warranted. Now, pancreatitis is a side effect that's often cited. There was a study done with over 17,000 subjects, and they actually found more pancreatic issues in the placebo group than the semaglutide study. So it's not actually showing up in the literature. However, we do know that rapid weight loss can cause blockage of the bile ducts, increasing the risk of gallstones. That definitely can be a problem. And then what about the black box warning? So there is a black box warning on Ozempic, and that was done in rats where they injected them with high doses. And sure enough, it did cause this rare type of medullary thyroid carcinoma. So we're not seeing it showing up in humans at this time, but it's definitely a possibility, something to keep in mind if this was something that you would ever want to consider. Now, another side effect that I've seen is gastroparesis. And so this can be quite damaging. This is the one that we're going to see people going into hospital for because they're just not having the gut moving. So we might see, vomiting or all kinds of digestive issues with gastroparesis. So gastroparesis just means the movement, the gut's just not moving. There's inflammation, we're not seeing things move along. Well, vagus nerve damage is the most common cause of gastroparesis. And so what can cause vagus nerve damage? Chronic stress, insulin sensitivity, diabetes, and viral infections can all actually be a cause of vagus nerve damage. So it makes me wonder, could the Ozempic effect of gastroparesis be that we've taken a fragile system and we've added these high doses of the semaglutides that pushes an already fragile system over the brink? In terms of vagus nerve damage, things like GERD, acid reflux, again, the gastroparesis, or even irritable bowel symptoms. And so I personally do think that when we think about dosing hormones, we need to think about dosing semaglutides in the same possible way. And so Tina Moore is really touting this idea of microdosing. So microdosing is using the lowest possible amount to create positive change. The idea is to start low and go slow. And lifestyle changes are non-negotiable. So weight loss cannot happen. We need to be doing regular measurements and doing an entire body scan where we're looking at the amount of fat, the amount of water, the amount of muscle to make sure that muscle isn't being lost. And the idea is it's not for lifelong. This is really to buy us time as we heal and mend other things that might be going on with our body. So people will often say they're doing a low dose, which is like a 0.25, which is the starting dose of Ozempic. Well, a microdose would be about 0.05 or possibly 0.1. Everyone's going to be different. But then let's also look at the ramp up. So the regular dose of Ozempic is to start at 0.25 and to ramp up every month. We're doubling it. Now, what's interesting when we look at other hormones, like let's look at thyroid, for example, at the 3-month mark that we know that sometimes tissue begins to get saturated. And if other areas aren't supported, so in thyroid, we have to support the adrenal glands. And it's often at the 3-month mark that we tank out thyroid or we tank out the adrenal glands if everything's not being supported. Could this also be happening with Ozempic? So instead of doubling the dose at 3 months, from 1 milligrams to 2 milligrams, this could be a time to actually take a break or back off or change it completely and switch to a different kind of semaglutide because there's many, many out there. And so let's just think about dosing for a moment. How did we get to this dosing? Well, drug companies want to be effective with the new drugs that are coming out. And so they're going to go with the highest possible dose to be effective. Think about birth control pill. So women will still come to me and they'll tell me they're on a low dose birth control pill. Well, it still has to be a pretty potent dose if it's going to tell your body to stop ovulating. But people say that because what we used to give was huge, like way, way, way higher doses. And I believe that this is probably what's happening with the semaglutides because we've taken a peptide that's a normal part of our physiology and we're giving it in massive doses. And we know that if somebody's already metabolically busted in some ways, we can't necessarily predict how the body's going to react with this new drug or with this new hormone in it. And so we have to be really slow and monitor. And so I do feel that for many of us on our weight loss or even our anti-aging journeys, GLP-1s might be a possible tool in our toolbox worth using, but not at the way it's being presented and not at the doses that are being talked about. It would be these tiny little micro doses where we start low, we go slow, we monitor well, and we understand all the other things that are going on in our body. And then we have to do all the other things that we would do for anti-aging or weight loss, hormonal support, dietary changes would be non-negotiable, especially when we think that idea of malnutrition. If you're eating less, that means that every single bite that you put in your body needs to be high nutritional value. We want to think about exercise as medicine, especially weightlifting, so we don't get into cachexia or any muscle loss. And then living an insulin sensitive lifestyle. So making sure we're supporting the adrenal glands, the thyroid, insulin in general, that whole leptin insulin cycle. Looking at things like sleep and melatonin, cortisol and inflammation, and other metabolic issues that might be coming up. So the whole idea of today's talk was, are GLP-1s right for you? And it's something for you to think about. They might not be right. We talked about a lot of the side effects, but if you are thinking that you might have insulin sensitivity, and there are different biomarkers for us to look at this besides just the one I mentioned, the hip to waist ratio, for us to understand insulin sensitivity. If your HbA1c is above a 5.5, you're definitely insulin sensitive. But I'm seeing a lot of people that are insulin sensitive with their HbA1c still being much lower than that. So trying to understand if we're starting to creep up into that place, because we definitely want to make sure that you don't get into a diabetic place. Is there metabolic syndrome creeping up? Is there inflammation? Tina Moore's using semaglutides a lot for autoimmune cases for great results, which is very interesting. Aging in general, because our GLP-1s go down as we age, and then also looking at things like neuroinflammation. So definitely we would need to do a risk-benefit analysis, and very important, medically supervised, go slow and low, and be very, very cautious with your ramp up.